Well, welcome, Dr. C. I am so happy to have you on my show again. I just, love following all of your stuff on Instagram. You are out there and advocating and educating and all the things. And we just had this conversation about coming back on the show to talk about something really super important, and that is the restoration of sensation with our breasts. And so,
Absolutely.
welcome. How are you
Thanks.
doing?
Yeah, I'm doing very well. Thanks, Jamie. Great to be back. Good to see you again.
Good to see you
You're
too.
doing amazing things.
Well, thank
Podcast
you.
is growing at a rate of knots. That's phenomenal work.
Yeah,
Congratulations.
thank you. I just have this fire in my belly, as I told you before, to really help, shorten that learning curve for people. And as we talked about last time, we talked about, shared decision making
Mhm.
and the importance of shared decision making. We're going to talk a little bit about that at the end, where we talk about, the importance of choosing your team and,
Mhm.
who you're comfortable with working with, but also that breast advocate app, which I'm going to definitely bring up again because I do have them always in my show notes now. And so I
Thanks. It's
love
awesome.
showing that off because it is so brilliant. But
Thank you.
today, we are going to be really getting into this really important topic. At the beginning, when I found out that I had to have a mastectomy, and I didn't
Mhm.
even know what kind of surgery I was going to do. I thought that it was all there was implants. That was before I even knew anything else about what kind of other options I had. But one of my biggest fears was losing that sensation in my breasts. We women love our breasts. It's what makes us, I mean, I know that that's not all of what makes us female, but that sensation is very important, for intimacy and, things like that. And so I want to ask you, is there any way to bring that sensation back to the breast? And we'll talk about, when that is possible, when it might not be possible.
Mhm.
So let's talk.
Yeah. So short answer is yes. It is possible to preserve and or regain some feeling, right? So I was careful which words I used there because it's important for women to know that we're not talking about 100% preservation being guaranteed, and we're not talking about 100% restoration of sensation being guaranteed. So there are definitely some very, very important nuances. But at the end of the day, the message is this. Many women, and maybe even most women, I think it's most women in my experience, when they have a mastectomy, they lose feeling. So it's exceedingly rare to have normal breast sensation after a mastectomy. So the main point here is that there's a conversation to be had, and that there are options for women to end up with a result that is absolutely better than being completely numb, right? So you mentioned intimacy. We're also not talking about maintaining 100% erogenous sensation. Some women have some erogenous sensation, but most women do not, right? So I'm painting a dark picture here, telling you of all the things it isn't. But at the end of the day, I have yet to meet a woman who would turn down this option because she's not going to have 100% what Mother Nature gave her. So the ability to feel a touch, the ability to feel a hug, the ability to know that you're being touched during intimacy, even though it's not necessarily erogenous, or it usually isn't. Those are all very important things. The knowledge that you won't unknowingly burn yourself because the the skin over your breast now has protective sensation, right? So that's a big deal in and of itself. So we have seen, thankfully it's becoming less frequent, but we still see it. We see women come from other practices with full thickness skin loss, with full thickness burn injuries to their breasts after they've had mastectomies and reconstruction, because they'll may have some achiness, or they'll have some sort of pain or discomfort, and someone will tell them, oh, why don't you put a hot compress on your breast? That really helps. And so they'll do something like, this happens a lot, but they'll get maybe a face washcloth or something, and they'll put it in some water, and then they'll pop it in the microwave so that it's nice and hot, and then they'll put it straight on their breast without testing how hot it really is. And then because they don't have any feeling after the mastectomy, the skin basically gets burned. And so, we've had women come to our practice with their implants basically exposed because of this full thickness skin loss from the burn injury, from putting something hot on the breast and the patient not realizing how hot it was. So first point is, for any woman who's had breast reconstruction, or mastectomy without breast reconstruction for that matter, because it's not the breast reconstruction that makes you numb, right? It's the mastectomy that cuts the nerves. So even if you've chosen to go flat or have aesthetic flat closure, you can still experience the same numbness, right? It's not just for reconstructed ladies. But if you're ever going to put anything warm on your chest, for heaven's sake, please test it out on a normal part of your body first. So the forearm, the skin over the inner part of your forearm, just beneath the elbow area, that skin is pretty sensitive and pretty thin. So if you can tolerate that, if you can tolerate heat on that part of your body, then it's probably safe to put it on your breast. Right. So
yeah, I've never even thought about that.
Yeah, I mean, but it happens. It happens all the time. It's really unfortunate. So there's another opportunity there to educate. But so yes, whether you've had breast reconstruction or not, that's another important point. It's the mastectomy that leads to numbness. It's not the breast reconstruction. There was an article in the New York Times, I think it was January of 2017, if I'm not mistaken. And it was about numbness. But the tone of the article, I took issue with. It was great because it got people talking. But the tone of the article was a little bit unfortunate because it kind of blamed the breast reconstruction for the numbness, which is just factually wrong. It was fair enough to highlight that back then most breast reconstructions didn't reconstruct nerves that provide feeling. That's a fair point because that was the reality for most practices anyway. But I remember going to breast cancer conference the following Tuesday. We have breast cancer conference every Tuesday morning. And I was, I received a barrage of really kind of very, it's quite aggressive questioning from our breast surgeons. It's like, did you see this article in the New York Times? What are you telling your patients about them being numb? I said, what am I telling my patients? What are you guys telling your patients? Because it's the same patient, and it's your operation that's causing the numbness. Oh. It's my challenge to restore the sensation, but the fact that they're numb, it's not. The initial shortcoming is not ours. It's the mastectomy.
Right. Right. I mean, that kind of makes sense to me.
Right. It's like, that's why even if you go flat without breast reconstruction, that's why you have the same resulting numbness. It's the mastectomy that cuts nerves, right? So Now, it was a very good article because it got the conversation going, and just the reaction from our breast surgeons highlights the lack of understanding of what the true issue is. So fast forward to today, and we have two approaches here. The first approach is to preserve as much feeling as you can, because preservation is always better than reconstruction, right? So our breast surgeons now, many of them are way more cognizant of breast nerves that provide the feeling. There are several nerves in the breast, and they try to look out for them when they're doing the mastectomy to try and preserve the nerves if possible. There are a couple that are super important for the nipple and the areola, especially for women who are having nipple-sparing mastectomies. But there are some main nerves that supply the bulk of the breast feeling, and there is a lot of overlap between the nerves too. But if you're cognizant of the nerves and you're trying to look out for them, especially the main ones that tend to be larger caliber, then you have a much higher chance of being able to save them if possible, right? So there are surgeons now who are really trying to get the message out in terms of the breast surgery field, and in terms of nerve-sparing mastectomies. Anne and Zeev Peled, it's a husband and wife team in San Francisco. She's a plastic surgeon and a breast surgeon. Zeev is a nerve surgeon, and they've done a phenomenal job advocating for patients and for getting the word out about nerve-sparing mastectomies. Oh. So if you haven't interviewed
I was going to say
Anne Peled yet, I strongly recommend you give her a buzz. They're both lovely. They're phenomenal people, as well as wonderful surgeons. So massive plug for their work and what they've been doing. And Anne is wonderful, so hit her up. So she's very much been pushing not just nerve-sparing mastectomies within her breast surgery niche, and within the societies for breast surgery that are out there. But she and her husband are also getting the word out about nerve reconstruction.
So is her husband the reconstructive surgeon?
Well, they both do it.
They both do.
They both do it. But
are they both microsurgeons? I know that's like the big buzzword. Like we need to know if they're microsurgeons and that they've done tons of these. I know you've taught me a lot about that. The other surgeons that I have interviewed, Dr. Potter and Dr. Cabling, it's like it's so important to know what their experience is, what kind of experience they have.
Yeah, for sure, absolutely. So you definitely want to go with, irrespective of the procedure, you definitely want to research and find someone who does a lot of whatever it is that you're seeking or whatever it is that you need, irrespective of surgical specialty or any medical specialty for that matter.
Right.
But anyway, so nerve-sparing mastectomies are a thing, and that's something to discuss with the breast surgeon. Okay, because again, having sensation after breast reconstruction, the plastic surgeon is only half the team. The breast surgeon determines how much feeling you could preserve by preserving those nerves. So if your breast surgeon doesn't offer nerve sparing, you should ask why. And we'll go into the reasons why people don't do things later on, but don't listen. Sensation is super important, and any feeling beats being completely numb. So you've got to have the right conversation, and you've got to be willing to have the right conversation with your healthcare team. Beyond preserving, and there are some reasons why you can't preserve the nerve sometimes. Sometimes you don't have the right anatomy, right? So the nerves come out of the chest wall and they travel in the breast tissue. And a lot of them travel in the subcutaneous fatty tissue just beneath the breast gland. So it is possible to preserve some of the nerves. Now, a lot of the nerves dive into the breast tissue, and so as you're removing the breast tissue, you end up cutting the nerves, even if you're trying to preserve them, right? So even if your breast surgeon is trying their hardest, it's not always possible. You also don't want your breast surgeon to leave a bunch of breast tissue behind just because they're prioritizing your feeling, right? So you got to get the right operation. And with the mastectomy, you've got to remove as much, anything that looks and feels like breast tissue should come out. Now, no mastectomy is 100% complete. So what does that mean? It means that there's always some breast tissue left behind, which is why women who have mastectomies and then go on to have MRIs, often you'll see some breast tissue on the MRI, and then women will freak out and say, oh my God, my surgeon didn't remove all my breast tissue. Well, they removed everything that looked and felt like breast tissue, and sometimes there are some breast tissue for most women. It's not like a hard-boiled egg where you've got the egg yolk in the middle and there's this obvious demarcation between the egg yolk and the egg white, in a hard-boiled egg. It's not. The vast majority of women are not like that. In most women, the breast tissue kind of spiders out, it's got tentacles, and it kind of spiders out and extends out between the fat, and it's impossible to get every single breast cell. So anyway, even if you're trying to preserve all these nerves, a lot of the time you can't because of the patient's anatomy. Then there's also, in a patient who's got cancer, the tumor can sometimes be in a location where you can't preserve the main nerves, right? So you got to get the cancer out. And so there are a bunch of reasons why, even if you find a breast surgeon who knows about nerve-sparing mastectomies and is willing to do it, there are several reasons why you are still likely going to experience patchy numbness, even if you have some feeling, right? It's very common in women who have nerve-sparing mastectomies where they have areas of, fairly good sensation, then they've got areas of a little bit of sensation, then they've still got a numb spot, and then it's kind of patchy. It's not uniform.
That's me.
Right. So, yeah. So, but again, that's better than a completely numb breast. So anyway, so those are the reasons why, even with a nerve-sparing approach, you can't be guaranteed to wake up and have full feeling, right? So you got to have appropriate expectations. Then, as far as what we do as reconstructive surgeons, once our breast surgeons are done with the mastectomy, we'll take a look. We'll see if we feel the nerves are intact or if they're not. And if we see a nerve has been cut, and if it's a main nerve to the nipple and the areola, or a main nerve to the rest of the breast, there's some very specific ones that we look for on the inner part of the breast, near the breastbone, the sternum, and then some nerves on the outer lower part and over the side of the breast too. So we look for those nerves, and our breast surgeons, a couple of them have taken the whole nerve sparing thing to a whole new level, and they have this immense sense of pride. It's like, hey, look at this. How'd you like this? Huh? You like this nerve? You like this nerve? So, a lot of the time you can't see the actual nerves, but you can see the tissue that's been left behind, and where the nerves come out of the chest, and that it's highly likely that the nerve has been preserved. Other times you see a nerve that's been cut and it's very obvious it's been cut. So now you have a target to reconstruct. So what we do at PRMA is whenever we don't feel a nerve sparing technique has been done, and we see that there's a nerve that's been cut, we'll go ahead and reconstruct it. And this isn't quite as good as preserving, but again, it beats a numb breast. So what we'll do then is, with the techniques that we do mostly at PRMA, which is tissue reconstruction, and as you know, the DIEP Flap is the main procedure that tissue reconstruction practices perform. So the DIEP Flap is what we call the workhorse. It's kind of the Cadillac tissue reconstruction using the lower abdomen. So what we do routinely is, when we take that tissue and transplant it to the chest, we also take a nerve with that tissue that was basically providing feeling to that tissue on the belly. And we take the nerve with the skin, with the fat, and we take a nice length of it, and then we can connect that directly to the cut nerve in the chest.
Fascinating.
And there are different ways to transfer the tissue. There are different ways to position it so that the nerve endings reach. Sometimes if the nerve endings don't reach, you can use a bridging nerve graft, which is a cadaver product. It's a human product from cadavers, and it comes in various lengths. And so if you've got a nerve with the flap that doesn't quite reach the cut nerve in the chest, then you can bridge the gap with this cadaveric nerve graft. In our practice, we don't use nerve grafts very often. We like the product very much. When we do use the nerve graft, we use a product called Axogen, which we think is a great product. It's just the only reason we don't use it on every case is because we don't need to, because we do things in a way where we can connect the nerve endings directly, and we just don't need to use that. The reconstruction technique, though, needs to be different when you're doing implants, right? Because when you're doing an implant reconstruction, implants come out of a box, whether, if it's a direct to implant, you're putting in the permanent implant. If you're doing a tissue expander reconstruction, it's a staged approach. But obviously, neither one of those man-made devices have a nerve. So what do you connect, right? So that's where the nerve graft is super helpful, because then you can use the nerve graft. If you see a cut nerve, you use the nerve graft and connect one end of the nerve graft to the cut nerve in the chest, and then the other end of the nerve graft you can connect to a stump of the nerve under the nipple areolar complex. And that's actually the technique that Anne is popularizing and has popularized. So, so even if you have an implant-based reconstruction, and you don't use your own tissue, you can still get a nerve reconstruction if your surgeon offers it. So we have people that travel to PRMA from all over. I mean, 10, 15 years ago, they were traveling for the DIEP Flap because there weren't so many people doing DIEP Flaps as there are now across the country. Now, patient access, while it's still a problem, and we're not there yet, it's a lot better than it was, 10, 15 years ago. But now a lot of people are traveling for the nerve reconstruction because, their local folks don't offer that, and they kind of put it down. Whether it's nerve-sparing mastectomy, they can't find a surgeon that will do that, and then you can't find a plastic surgeon that works with a breast surgeon that will offer reconstruction. So sensation is really it's the next kind of frontier that we have to cross in breast reconstruction. I mean, so breast reconstruction may not cause the breast numbness, but we have the opportunity to fix it, and add that. And really, it's the next. It's very obvious, and it's well overdue. Especially if you have a holistic approach to breast reconstruction, which we should all have, and it does really address the remaining aspect of restoring function that we haven't been doing a good job of addressing. I remember early on in practice, when I was talking about tissue reconstruction versus implants and the pros and cons of each. One of the pros of tissue is its consistency, but I wasn't thinking in how I would phrase things. So I would say things like, an implant can provide a nice, very cosmetic, augmented result, if that's the look you want, and a tissue reconstruction provides a more natural feeling result. And then I never realized way back then, I've been in practice for almost, well, I don't want to say it's been so long, but anyway.
Actually, yeah, you do, because that gives you
okay, 20
lot of
years.
credibility.
All right, 20. Okay. So, but back then, when I would say, if you use your own tissue, it feels more natural. I didn't think of the implications that the patient was hearing, right? And so, because ultimately, who does it feel more natural to? It feels more natural to me when I examine you as your physician. It may feel, it feels more natural to your partner, but you many times don't feel anything, right? So what I meant was the consistency of the breast is more natural. But when you use the word, it feels, that means different things to different people. So you have to be very careful. But now fast forward, and actually we've been doing nerve reconstruction. We started doing nerve reconstruction early 2000s, I think, in our practice. That's been many, many, many years. We've been part of a multi-center trial. One of the reasons why some surgeons, or many surgeons still to this day, refuse to even buy into the concept is because they say, well, it just doesn't work, which isn't true. It does work. Now, if you choose to not offer something because we can't guarantee 100% preservation, 100% restoration compared to Mother Nature, then I can't help you, right? If that's what you need. But there are no, what we call the morbidity, in other words, the risk of complications is so low. There really are no risks associated with the procedure. It adds a little bit of time, especially once you're over the learning curve. It's negligible in terms of OR time. So it's not like, oh my God, you're under anesthesia now for so much longer because of this nerve reconstruction. That's false.
So it's worth a shot. I mean, it's at least.
Well, why wouldn't you? I mean, it's for me. It's like, okay, it's not 100%. Okay, it's not 100%. So what? It's better than nothing. And actually, It's a whole lot better than nothing, and it's a whole lot better than the alternative. It's not even just a little bit, because as I said, I haven't met a single woman yet who we've done a nerve reconstruction on, or nerve sparing, and who has feeling that regrets having feeling. Have you? Have you met anyone who regrets having feeling after breast reconstruction?
I have not. Yeah, and there's been a lot of conversation out there about sensation, and so I mean, most of the conversations that I have, people don't know necessarily about that option.
I think the only regret I've come across is women, wishing their surgeons would have mentioned it or offered it. So there's still a lot of unanswered stuff, right? A lot of unanswered questions, a lot of things we don't know. Is using a nerve graft better than not using a nerve graft? Should we be using a nerve graft in everyone? The data doesn't suggest that, but we don't know for sure. What we know is that whether you use a nerve graft or not, reconstructing the nerves leads to better feeling compared to not reconstructing the nerves. And it also provides faster return of feeling compared to not reconstructing the nerves. We also know that if you don't do a nerve reconstruction, some women will regain some feeling on their own, regardless, right? So that's another reason why some surgeons say, refuse to do it or refuse to consider it or explore it, because they say, oh, well, I've had women that have some feeling anyway, it comes back. So, well, no, that's true. Some women do regain some feeling even without a formal nerve reconstruction, because if you're doing a tissue reconstruction, cut nerves continue to grow back into the tissue that you've transferred, and at some point you may get some feeling back. It's absolutely correct. So there's also a hope that, you know, even if you haven't had formal nerve reconstruction, and especially if you've had a tissue reconstruction, you may still get some feeling back, especially if it's been less than 2 years, right? By 2 years, most people, it is what it is, right? So if you had reconstruction 10 years ago, you're probably not going to experience more over time at this point, right? So in terms of return of feeling.
What about, somebody who has a mastectomy and they have, I guess delayed reconstruction, and also how does radiation, play a role in that?
Great question. So delayed reconstruction, we look for a nerve that's been cut, and we usually find one. So the delayed reconstruction actually is probably has of all the patient demographics, the patient groups, probably the delayed reconstruction folks, I think, experience the greatest change, because they have typically a much larger area of skin that has to be added as part of the flap. You know, most people have a big skin paddle, and so that's a big area that you can potentially restore some feeling to, and so the delayed folks really appreciate it. And in terms of radiation, that's another great question. I used to not do it or not stress about it in women who had radiation, because radiation kind of sterilizes tissues and it prevents we thought it would prevent nerve regrowth, and so there wasn't any point in doing a nerve reconstruction. But then I think, well, now we have studies that show that it helps with radiated patients as well. So the studies that we have now, and there have been several papers, especially out of Holland, there's a group that's published a lot out of the University of Maastricht. So we know now. So number one, reconstructing nerves restores more feeling and quicker than not reconstructing nerves. And we know that also applies to women who have had radiation. Now, the radiated flaps don't do as well. So women who have had radiation, the degree and the quality of feeling that they get back isn't the same degree as women who have not had radiation. Right?
Does it make a difference? Does it make a difference? And I don't know whether PRMA, you all do this over there, but I know that there are some surgeons who will do mastectomy and will delay the reconstruction because of radiation. Is there, does that make a difference? Like if you were to do immediate reconstruction, is it possible versus waiting?
Yes, you can do nerve reconstruction in any of those situations.
Okay.
Yeah.
I know there's just so much question around, that revolving around this radiation. I never had radiation, and I didn't know that I wasn't going to have radiation until after my DIEP Flap, until they pulled the lymph nodes and knew that they were not in my lymph nodes, and I ended up not having to do it. But there's so many women who've had to do radiation. So it's still worthwhile having a nerve reconstruction, even if you've had radiation. Okay.
So if you had a mastectomy, and then you had post-mastectomy radiation, and then you go and you have your DIEP Flap, you should absolutely consider it.
Okay. So
because it's an option.
So questions we need to add to our list of questions that we ask this team, right? We want to include, do you do sensation restoration, and what does that look like? And so these are questions that we need to add to the list for sure.
Yeah, so both for your breast surgeon, if you're having an immediate, and I mean, if you haven't had the mastectomy yet, the breast surgeon, because you want to do a nerve preserving if possible, and then from the plastic surgery team, whether they do it. Yeah, for sure.
So now that we know that really, the nerves go away because of the mastectomy, and if the surgeon does perform that preservation after mastectomy, what if they do that and then the reconstruction person comes in? Can it sort of be a doubled up opportunity there?
Yeah, that's what I'm saying. So
Yeah.
so that's exactly right. So the breast surgeon tries it's not, I mean, if the breast surgeon does a nerve sparing and then the plastic surgeon looks at the nerves and they look intact, then there's nothing to reconstruct. You're not going to want to cut a nerve just to say you've reconstructed it. That's unethical, right? And so we have patients traveling to us now for this. Or actually not just now. It's been many years. And I tell there are women that travel to us for nerve reconstruction, and they don't even get a nerve reconstruction because they get nerve sparing. But you can't guarantee that they're even going to get the nerve sparing technique until the mastectomy's been done, and you can see, right? See what their anatomy is like, see how the surgery went, see what your breast surgeon has done, and there's communication during the surgery, obviously. And also the other issue is that even if you see the nerves and they look like they're intact as they travel into the mastectomy skin, you don't know what happens to that nerve as it travels, as it branches, and as it travels throughout the skin, right? So it may have still been cut somewhere else, but that doesn't really matter, because if your breast surgeon has tried to spare the nerves, you're going to end up with way more feeling than someone who prioritizes, how much tissue they leave behind. There are some surgeons that say, oh, a good mastectomy, you should have 8 millimeters of tissue. Well, that depends on the patient's anatomy. It depends on the patient's BMI, how much fatty tissue they have under the skin. It depends on so many things. And, there are layers, a quality mastectomy and someone who's got a super low BMI, that tissue is going to be very thin that's left behind because that lady doesn't have much fat. And a lady who's got a much higher BMI, she should have much thicker mastectomy flaps left behind, mastectomy skin left behind, because she's a bigger lady. And, if you've got a BMI of 35 versus a BMI of 18, you have a different thickness of adipose tissue, of fatty tissue. The fatty tissue layer underneath the skin is different in those two individuals. So if a high quality mastectomy focuses on removing the breast tissue, then you should absolutely not have the same mastectomy skin thickness left after the mastectomy in both those people.
Okay, makes sense.
Right? So good breast surgeons know that. Not everyone has the same approach.
Okay. In your Breast Advocate app, I was just looking up on their nerve sparing. When you go through the wizard, right? That's what you called it on there. Are there options on there? Because I didn't see that. So are there options on there that you can answer to educate, make people aware of what to ask and to even know that's even possible?
Yeah, I mean, in the wizard's just a question, right? It's like, how important is breastfeeding to you? Or I can't remember the question we asked, but it's just a question. So the education is in the knowledge center.
Okay.
And then actually the articles that we have in there, I think Anne actually wrote one of the articles on the sensation.
There is free inferior. Let's see. There's a flap harvest with sparing of. Yeah, I'm just looking at some of the resources in here. I'll have to look for that because that's not something I was even looking for at the time. I do remember asking something about nerve sparing, and one of the breast surgeons said that's not even possible. Like,
Yeah.
they said
I respectfully beg to differ.
Okay, well, that's good. Yeah, good to know, because they said that, despite what people say, that really isn't something that can happen. And now we really do know that it can happen. That's I'm curious.
Yeah.
Do you
And
have
and there's plenty of published data on this,
Okay.
so for ladies who like researching articles and stuff, and if you go to PubMed, and actually the articles are in Breast Advocate, so it's even easier to
Good.
kind
I
of,
love that. Love
yeah.
the Breast Advocate app. So nice to be able to have that all housed in that area. So I had a question I was going to ask you, and then I just sort of left my mind because I started thinking about the Breast Advocate app. Oh, I know what I was going to ask you. You probably have patients that have told their story about that. Yes.
Which bit about feeling?
Yeah.
Oh,
About
yeah.
maybe, yeah, like someone who might want to come on here and talk about it.
I'm sure. Yeah.
Because people want to know. I mean, I know
won't
ladies
be
out there want to know.
that shouldn't be an issue.
Okay.
Yeah.
Okay.
Yeah.
Well, I just I'm really glad that you reached out and wanted to talk about this, and that does add another layer of how we pick our team.
Yeah. I mean,
How the surgeons work together.
yeah, and then there are different. I mean, the team thing for breast recon, it kind of depends on. So it's procedure dependent, right? If you're when you're picking your team, if you want implant reconstruction, if you decide that's what you want, then you really you should focus on the pairing, the breast surgeon plastic surgeon pairing. Don't pick a breast surgeon and then go off and pick a plastic surgeon that never works with that breast surgeon. You should always pick a pairing, because you should pick a plastic surgeon that works with a specific breast surgeon more often than not, and vice versa, because you have an understanding between those two individuals. That's very important in terms of your outcome.
Okay.
So the level of trust that needs to happen between the cancer surgeon and the reconstructive surgeon, it's got to be a known relationship, and it's got to be the flow to the procedure and the decision-making process and the respect to each party's importance in the decision-making, where to put the incision, the nerves, what's the follow-up reconstructive surgery going to look like if it's going to be more than one stage, all these things. The model that exists in some places where the breast surgeon does their thing and then the plastic surgeon just comes in and there's been no input and the plastic surgeon is just left to just make the best of it, that's not what you want.
Yeah, that's the communication is
it's
key.
Massive.
Yeah.
It's massive.
It's like being a team teacher in a classroom,
Yeah. Yeah. And then if you're doing, microsurgery, then the whole team thing, that's a whole new level, whole other level, because microsurgical procedures are complex. You can do those, a good surgeon, can do those with a PA and get away with it most of the time. I know several across the country, good surgeons that do these surgeries with a PA. But I personally, we don't do that at PRMA. We have two surgeons on each microsurgery case, because those cases, when they go well, they go well. And you know what? It can be straightforward, and things go well and things go smoothly and things are slick and you get done at a decent hour and everyone's happy. It's when things don't go according to plan, when you really want that second person there. And microsurgery is very complex. And one thing we're seeing now with insurance, and I bring this up too because you and I have spoken about the insurance issues before, and the whole S code debacle for DIEP flap surgery and perforated flap surgery. And what's interesting now is that insurance companies are actually turning down the co-surgeon, the second surgeon. So now there's this push for surgeons to do more and more on their own, which is the next battle we're going to be facing, because that's not pro-patient. That's not patient first. That's not advocating for the patient.
Cutting corners.
Yes. I mean, we feel it is. Now, again, if you've got, listen, there are surgeons that can pull this off, but just because you can pull something off doesn't mean it's a smart approach, right? And if I'm the patient, I don't want to hear that you can pull it off. I want to hear that you have 2 microsurgeons on my case.
Yeah, and that you're very confident it's going to work out well. Yeah, no,
and it's going to work out, right? And so that's another battle now that's kind of starting to heat up. And we're seeing, I'm seeing lots of colleagues around the country, the conversations we're having, lots of colleagues that used to work with another surgeon and now not able to as much or at all because of insurance contracting.
So this is one of the reasons, like, we have a lot of conversations in our support groups about insurance. And I really wanted to go to PRMA, but I couldn't because my insurance wouldn't approve it, or wherever you're deciding to go. So it's really frustrating because, I feel like people should be able to go wherever they want to go to get their surgery according to the surgeons that they've got maybe talked to. And so it's very frustrating. So my question is how do we help? How can we leave something maybe in the show notes that we can get out to patients and patient advocates? What can we do from our angle?
Yeah, great question. I think it's important to discuss the patient safety aspect of it. If you, 2 microsurgeons are always going to be better than 1. And so advocate for yourselves. And if you have a choice, just take that into account. And then, if your insurance is giving you a hard time, then it's funny. Insurance, I think, insurance plans and insurance companies they do not like getting complaints from patients. They get complaints from surgeons all the time.
Right. So everything's negotiable.
Everything, you're the customer, right? So ultimately the patient is the customer. And so you have a stronger voice as patients, I think, than surgeons do.
Okay, well,
so I would say talk about it. I would say bring it up. I would say if your insurance company denies it and you want to go to a place that is using 2 surgeons, make a stink. It's not like it's interesting. If you guys were privy to the finances on the back end, you would see that it's not even the financial decision that's not really the conversation, because the X that they pay more for 2 surgeons is so negligible. That's not even the point. So it's just using things to say no, right? So it's the latest thing after the CMS hearing and after the S code issue was remedied and the sunsetting of the code wasn't happening anymore. And I think you and I discussed about winning the battle and losing the war. the next part of the war is the second is the co-surgeon, is the second surgeon, because
Okay.
that's where insurance companies are focusing now, and they're squeezing surgeons. So now more and more surgeons, if they want to do the surgery, they have to do it on their own with a PA. So how is that putting patients first?
Yeah.
We can dress it up all we like, but ultimately, how can one microsurgeon ever be better for the patient than two microsurgeons for such
Right.
a complex procedure?
Well,
Makes
and
no
I think
sense.
that insurance companies don't even quite get, why things are like, they don't see that side of it. They just see the bottom line, right?
Yeah, they do,
Yeah.
and they don't. The data's out there; it's published. Two surgeon model is the gold standard. It's been that way. That's not a new revelation, right? That's standard of care.
Right. Right.
So I think get the word out, and patients should use their voices
Right.
because it's very
Okay.
powerful.
Well, I'll be keeping my eyes open on that, and just keeping a close eye on what's going on and listening to what's going on and continuing to follow you. I really like that you are a very reflective surgeon. You look back and
Thanks.
you think about things that you've said to patients, and you're clearly an empathetic surgeon, and that's why I really like you. And I've learned a lot from you. Um, and I'm glad to know that you actually can restore sensation, not necessarily 100%, but it's worth a shot. And if that's really important to people, which it is to a lot of us, then we know the right questions to ask. We also know the right way to advocate for ourselves with insurance companies, using our voice and making us stink and talking about things that aren't PC too. I always like that you like that, it's important, I think. And so with that, I really appreciate your being here and talking to us about that today. I will be in San Antonio. I think I sent you a message. It just so happens that I will be there in March. Because I'm a public board member for social workers here in Reno and in Nevada. And my new board member training is there in San Antonio, and I've never been there. So I'm going to be coming into town. I don't know if you're going to be there, but I'd love to be able to stop by and, see PRMA and meet you in person if it works
Oh,
out.
for sure. Yeah, we can.
Yeah,
Let's do that, and you can tour the facilities and take a look at our new place, Landmark Hospital.
I would love
So
that.
yeah, that'll
We
be great. Show
are
you around.
we are having a girls trip. Some girls that I've never even met before. I've known them for a long time because of the breast cancer, but I've never met them in person. I've met one of them in person when I had my last surgery. And we're making a girls trip to Perky Girls to get our nipple tattoos next July. I thought, why not just make a girls trip out of it? So we're all going to be coming to San Antonio in July to get that done. So why not
It's not.
why not have those silver linings out there, right?
Oh yeah, plenty of worse places to visit. San Antonio's lovely.
Okay,
July's
well, that's
pretty
what I
hot.
heard.
It's pretty
Yeah.
hot. July will be pretty hot, but that's okay.
Yeah, well, a bunch of us hot girls will be there. So
There you
anyway,
go.
so, okay, well, I appreciate your time and your energy that you put into patient advocacy. And, I'll see you on Instagram. And to my audience, I have all of Dr. Chrysopoulo's Instagram, and I think I have your LinkedIn in there and your website and the Breast
My
Advocate
link
app, of
tree.
course, and your
Hmm.
link tree and all the things. So I hope you have an amazing rest of your day and week. And thank you. Do you have anything else
Thank
to
you,
say
Jamie.
before we leave?
No, I just appreciate just you creating this platform. I appreciate you keeping it real. That's super important. Anyone can look up stuff online about procedures and stuff, but I just I appreciate how what you're doing allows people to learn about topics that relate to them. So congratulations and thank you. That's all I have to
Yeah,
say.
thank you for saying so. I really appreciate your saying that, and that you see that I do like to keep it real, and because that's really truly the only way to be. So, well, thank you very much. And to my audience, I will see you next time on the next episode of Test Those Breasts. Bye for now.